Hello, everyone. My name is Alal Said. Welcome to Soteria webinar. We received great feedback after the last two webinars. Therefore, we are continuing our series. Every webinar, we bring a variety of experts from different regions and facilities, so we can have good bridges of sharing the knowledge. As our CEO, Jan Savage, said before, that we are trying to compensate for the canceled course and congresses. Today, we will speak about the clinical implementation of MR guided prostate biopsy and its economic value. Please let me take a minute to introduce Soteria Medical for the audience who attend for the first time. Soteria Medical is a spin-off of Radboud MC in Nijmegen in the Netherlands. We are focusing on the MR guided interventions. Our main product is remote controlled manipulator, which is the commercial name, the RCM. RCM is a state-of-the-art in the IMPOR prostate biopsy and the interventions, CE and FDA approved. Actually, our team, my colleagues, they solved the formula to combine between speed, accuracy, and cost effectiveness. RCM is for IMPOR, transrectal MRI targeted biopsy and intervention. The MRI compatibility is fully covered for the RCM. We utilize the step motors for high accuracy position for the minute and the speed. We are covered across Europe. We are in Australia, in India, and Taiwan. We installed it this year for the first time in USA in Mayo Clinic in Arizona. Just a quick about the house rules for the webinar. All participants in the webinar will be muted except the presenters. You can use the chat button, as you can see, for general comments. For questions, for the Q&A button, please feel free to use it anytime. And we have dedicated time in the end of the webinar to answer with our speakers. Also, we will try in between to pick one or two questions, add a good swift between the speakers. Please feel free to contact us for demonstration and the question. You can also register for the upcoming live demonstration on October 15. I'm glad and proud to introduce my colleague and my speakers. So I will leave you now with my colleague Martijn Hogenboom.
Hi, good evening, good afternoon, everyone. So this is together with Allah, we will moderate the webinar session of today. Today we have three great speakers, I think, with a lot of knowledge in the field of prostate MRI. And I think that we have a nice schedule in where we have three nice talks. And I first want to introduce our first speaker, Peter de Visser. He's the professor. Actually, I want to congratulate him because he's promoted last month to the professor of genitourinary radiology and mammography. He actually also did a lot of research in the field of prostate MRI. Last EAU conference, he received an award for his paper on systematic review on the role of imaging in early prostate cancer. So we're really happy that Peter will give us a presentation about prostate MRI and MRI targeted biopsies, and to give you a first introduction with that. So Peter, you can start sharing your screen.
Okay, good afternoon. Yes, I hope you can see now my presentation. Is this ready? Okay?
Yes, we see it. Okay. Thank you very much.
So good afternoon, everybody. Indeed, and thank you for the invitation, Martijn, for this talk on this webinar. So I will talk about prostate MRI and the prostate MR targeted biopsies. So how is the diagnosis of prostate cancer made? Most patients do not suffer, do not have any complaints, and the diagnosis is suggested because the PSA level is elevated in the blood, or there is an abnormal digital rectal examination. The problem is that the PSA may also be elevated in cases of prostatitis or in BPH. And concerning digital rectal examination, since the existence of PSA, most prostate cancers are detected before they become palpable. They are still smaller. PSA offers us no information about the localization or the size of the tumor, how big it is, and if it is located on the left side or right side, anteriorly or posteriorly. So we add imaging to the PSA level to have some more information, and transrectal ultrasound and MRI are most useful for the imaging of the prostate. But with an elevated PSA and a suspicious imaging alone, we do not have the diagnosis of a prostate cancer, therefore we need histology. Histology is obtained by a prostate biopsy, and then it is looked by the pathologist who will report if there is a prostate cancer, yes or no. And in case of a prostate cancer, the Gleason score is important. A low-grade tumor, which is not very aggressive, will have, for example, a Gleason score of 3+3. An aggressive cancer will, for example, have a score of 4+5. So transrectal ultrasound is still the first imaging assessment technique. It can be done by the urologist in its own practice. And it's very good to delineate the prostate, to measure the size of the prostate. And sometimes a prostate cancer is visible. It's ideal to guide the prostate biopsy because ultrasound can show that the needle is placed in the prostate when a systematic prostate biopsy is performed. But often the tumor is not visible and we are not sure that we have a good representation with the course of the perfect tumor load in the prostate. When you compare these ultrasound images with MRI, we see immediately that the prostate cancer is much easier visible on an MRI. On the left side, we see a normal prostate where we see the differentiation between the peripheral zone, which has a high signal intensity, and a transition zone with more like multinodular. 70% of the prostate cancers occur in the peripheral zone, and they are visible as an area of low signal intensity on the T2 weighted images. The problem, however, is that not every low signal intensity on T2 weighted images is a prostate cancer. It may also be fibrosis or prostatitis or hemorrhage from a previous biopsy. That's why we add functional imaging techniques to the morphological T2 weighted images in a whole multiparametric MRI exam. The most frequently used functional imaging techniques are the diffusion weighted images, which give us images with the different B values, which tell us something about the cell density. And a prostate cancer will typically have a higher cell density, which represents as a dark lesion on the ADC map, as you see on the right top image. In the multiparametric MRI of the prostate, we also add dynamic contrast enhanced imaging. So we perform examination with contrast, and we see the contrast go through the prostate like we see now. And then we can make some curves. And prostate cancer typically shows a very strong vascularization. It will show a strong initial enhancement and a strong washout. Such a multiparametric MRI has been very good, but it's not easy to perform good quality images, and the interpretation is also not always very easy. That's why the ESUR, is the European Society of Urogenital Radiology, developed in 2012 guidelines on prostate MRI, and they developed also the PIRATS system. The PIRATS stands for Prostate Imaging Reporting and Data System. In 2015, this system was also adopted by the ACR, the American College of Radiology, and a new version was developed, PIRATS version 2. And in 2019, some refinements and clarifications were made to this PIRATS version 2, and so now we are in PIRATS version 2.1. So the PIRATS papers describe us what a good quality MR should be like, what the parameters are that are important, and also helps us to make the report, to make a correct diagnosis on the MR images. An important parameter of the PIRATS system is the PIRATS scoring, and it helps us to give an overall assessment category of the clinically suspiciousness of lesions that we see in the prostate. The different scores of the individual sequences can be combined into one overall assessment category that can be used for the whole prostate or for different prostate areas in the prostate. A PIRATS score 1 means that the presence of a clinically significant prostate cancer is highly unlikely. A PIRATS score 5 means that the presence of a clinically significant prostate cancer is highly likely. There's also score 2, 3, and 4. Score 3 means that the findings are indeterminate, are equivocal. Two examples. This is a patient with a perfectly normal prostate. We see normal images on T2-weighted imaging. We see no restricted diffusion. And as you also see, additionally, there is no suspicious enhancement on the subtraction images. This is a patient with a Pyrus 1 prostate. The presence of a clinically significant prostate cancer is highly unlikely. Another patient, we see a low signal intensity area on the T2-weighted images. We see a diffusion restriction in the same area, a low signal on the ADC map, high signal on the high B-value images, and also the lesion shows contrast enhancement. This is a typical Pyrus 4 lesion. The presence of a clinically significant disease is likely to be present. As you see in both cases, the added value of DCE is not very big. And in recent years, we have seen that the number of cases where you really need the contrast to find the diagnosis, to detect the clinically significant tumors, in 80% of the cases, you actually don't need the contrast. So there is more and more interest to change from a multiparametric MRI approach to a biparametric MRI. So omitting the contrasts. It would have several potential benefits. It would be cheaper because we don't need to pay for the contrast. It eliminates the possible adverse events of gadolinium, like nephrogenic systemic fibrosis and gadolinium deposition in the body. It would result in a significant shorter scan time, and then you could scan more patients, and it simplifies the interpretations. If there are less sequences, it's easier to come to the conclusion. So at the occasion of the EAU, the European Congress of the Urologists, the PRIME study has been announced, which will be an international multi-center prospective diagnostic study that aims to assess whether a biparametric MRI is non-inferior to multiparametric MRI. It will be provided by the same team who published the Precision trial in the New England Journal of Medicine. So this will definitely be an important study which will have important implications. If this study will show that a biparametric MRI approach is non-inferior to a multiparametric MRI, the biparametric MRI will become the new standard. So what's the accuracy of multiparametric MRI for the detection of prostate cancer? In this table, the strengths and the weaknesses are very nicely demonstrated. When you look in the rows, we have the Gleason score. The higher Gleason scores are on the right side. In the columns on the left side, we have the size of the tumor. And what we see is that a multiparametric MRI has an excellent sensitivity for detecting large and aggressive cancers. That's very good. When you look at the small, low-grade tumors, MRI is not good. Frequently, these small and low-grade cancers are missed. But maybe that's not a disadvantage. We can turn it into an advantage because the treatment of prostate cancer has changed over the years. In the past, all prostate cancers wanted to be found and were treated. But you had a definite problem of overdiagnosis and overtreatment. Patients were treated from a prostate cancer which would never give them any harm or would never cause the death. So nowadays, the aggressiveness of the cancer is taken into account. And we make a difference between clinically significant prostate cancer. These patients need treatments, maybe surgery, radiation therapy, hormonal therapy, or systemic therapy. But when a patient has a very small, low-grade tumor, active surveillance is the better option. It means postpone treatment and wait and look closely, perform a close follow-up, and only start treatment in case that there is an evolution to clinically significant prostate cancer. So MRI can be very helpful to diagnose the clinically significant prostate cancer and to avoid too much diagnosis of insignificant tumors. It's called the MRI pathway when we perform an MRI before the biopsy, because in the past, the sequence was first when the PSA was elevated, the next step was a systematic biopsy, randomly throughout the prostate, sometimes without visualization of the suspicious area. If we perform an MRI before the biopsy, we can decide when we see a suspicious lesion on the MRI, we can perform a darkened biopsy to the lesion. When the MRI shows no abnormalities, in this theory, a biopsy could be omitted. But we have to be careful and realize very well if we have normal findings on MRI, it's not only better to omit the biopsy, but the biopsy may be postponed, and a close follow-up is needed with the PSA follow-up and or repetitive MRI examinations to see what happens. Because we have to be aware that a low-grade prostate cancer is still possible, which can evolve into a more aggressive tumor. But at the time that the patient comes to you, we want to avoid the detection of indolent, clinically insignificant prostate cancers. In patients with a perfectly normal MRI who already had a previous biopsy showing a low-grade tumor, these are the patients that are good candidates for active surveillance. In patients that are candidates for active surveillance, it's very important to perform an MRI at the start of this surveillance to be sure that no high-grade tumor was missed. If there is a very suspicious lesion on the MRI, an added targeted biopsy may be needed. So that's what happened in the MRI pathway. When we see a suspicious lesion on an MRI, a targeted biopsy can be performed. Because this is what happens when we look in the past. We see here the finger of the urologist in the rectum of the patient. When there's a large tumor posteriorly in the prostate, the urologist will feel the tumor, and when he performs a systematic biopsy, he will hit the tumor and have a representative core of the tumor. But in a patient with a larger prostate and a smaller tumor, this will not be possible to be felt by the urologist. And when he performs a systematic biopsy, with the needles are traditionally only 2 centimeters in length, he will miss the tumor. This is not a rare case. In 30 to 40% of the prostatic biopsies, they are false negative. It means that the tumor or the most aggressive part of the tumor is missed. So if we have the information of the MRI on beforehand, we can perform a targeted biopsy based on the MRI findings. So how can we perform a targeted biopsy? There are roughly 3 methods: the cognitive transrectal ultrasound biopsy, the TRUS MRI fusion biopsy, and the in-bore MRI guided prostate biopsy. The cognitive TRUS biopsy is the easiest and the cheapest and the fastest way. It's just keep the MRI images in your mind when performing the biopsy. But you need a clinician who is able to look at the MRI images and to keep them in the mind and to have some idea when performing the ultrasound where exactly he is in the prostate. When you perform a cognitive TRUS biopsy, random biopsies, systematic biopsies can be combined with some additional cores to the region where the suspicious lesion is about located on the MRI. This cognitive TRUS biopsy is most frequently used in clinical practice, and for large prostate cancers, this is definitely sufficient. But for very small or anteriorly located lesions, this is less accurate, although not impossible. But with TRUS MRI fusion biopsy, such a transrectal ultrasound biopsies become a little bit more easy. This is a system where software is used to fuse virtually the MRI images with the ultrasound images. There are several systems on the market with electromagnetic fusion, mechanic fusion, elastic fusion. But be careful, it's not as easy as it seems, because there's often, there may be misalignment, there may be a systematic error. The more steps that there are to delineate the prostate and to determine the target lesion, the more errors that there may occur. But it helps for clinicians that are not used to look at MR images. If the radiologist on the MRI shows where the target is, it may be possible to perform the ultrasound-guided biopsy with the MR images fused. When a transrectal approach is used, random biopsies can be combined with some additional cores to the region where the suspicious area is highlighted by the software. But there are also transperineal approaches with this way. The transperineal approach reduces the infectious complications. The risk of prostatitis is reduced because you don't have to go through the rectum. This is an example where we, in clinical practice, we see the MR images and we see the ultrasound images, and they move together to delineate the lesion and to perform the biopsy. And then there's the in-bore MR guided prostate biopsy. I will not go too much into detail because in the next lecture that will also be mentioned. So here, the prostate biopsy is performed under MRI guidance in the MRI scanner. So only a few cores can be taken from the targets, or 2 or maximum 3 targets. Additional random systematic biopsies cannot be combined in the same session. And this is the most precise method for lesions that are very small or located at a difficult location, because you see the needle go through the lesion. You are sure that the needle is going through the target lesion. This system is more expensive than the previous others, and it's currently only available in expert centers. This is what it looks like. So the patient is in prone position in the MR bore, and we first put a needle guide in the rectum, and then the biopsy needle is put through the needle guide into the prostate where the suspicious lesion is marked. So this MRI pathway with performing a target biopsy to the suspicious lesion and no biopsy in the areas where there is no suspicious lesion, can we trust this? Is it enough to perform these targeted biopsies alone? Do we need additional systematic biopsies? And is it safe to omit the biopsy when the MRI is perfectly normal? These are questions that are still being asked nowadays, although there is quite some evidence that show that when you perform this MRI pathway, perform only biopsy to the targeted lesion, that it is superior to the systematic biopsy that has been done for years. There is the PROMISE study, there is the Precision trial, there's the MRI First trial, there's the 4M study. They are published in the New England Journal of Medicine, the Lancet Oncology, European Urology. So there is a lot of evidence at this time. And when we put them all together and conclude what the findings are, that is that when the MRI pathway is used, so when MRI is used as a triage test and target for the biopsy, fewer men will undergo biopsy. Up to 50% will have no biopsy. We can avoid a biopsy when there is no lesions on MRI. We need fewer cores because we only put needles in the place where the lesion is, only targeted to the suspicious lesion. Do we miss tumors? No. In contrary, we find a little bit more significant prostate cancers, and we have a lower detection of about 10% of clinically insignificant prostate cancer. So the tumors that we are not interested in, we can avoid the detection of these tumors. Based on these literature, the guidelines have been changed recently. So until 2018, concerning the EAU, the European Association of Urology guidelines, recommended in patients with an elevated PSA to perform first a biopsy. An MRI was only recommended before a repeat biopsy when the PSA was still going up in cases where the biopsy was negative. Since 2019, the EU guidelines have been changed, and now the recommendation is in patients with elevated PSA, perform an MRI before the prostate biopsy. And then, depending on the findings of the MRI, a biopsy can be targeted or systematic, depending on the clinical suspicion and the prior biopsy state. In 2020, also the American Association of Urology guidelines have now supported the use of MRI before the first biopsy. So what is recommended in patients that are biopsy naive, so patients who did not have a previous biopsy, and the MRI is suspicious, they recommend a targeted and a systematic biopsy. In patients who already had a previous negative biopsy and the PSA is still going up, a targeted biopsy only is enough. So only 2 cores, for example, to the lesion that is suspicious on MRI, it means a Pilot score of 3 or higher, this is enough. On the other hand, when the MRI is normal in patients that are biopsy naive, it is recommended to perform no biopsy if the clinical suspicion of prostate cancer is low, based on the clinical biochemical parameters, the digital rectal examination, the family history, and so on. If there is a high clinical suspicion, it's recommended to perform a systematic biopsy. So is it safe to omit a biopsy when the MRI is negative? Negative may mean that the MRI shows that in the radiology report, there is a Pilot score 1 or 2. This may be that the tumor is invisible, or that there is no tumor, or it may be that there is a misinterpretation. And when you look at the negative predictive value in the literature, there are wide variability. The negative predictive value, so the prediction if an MRI is reported as normal, what is the risk that there is really no tumor? It varies for any prostate cancer from 50% to 100%, and for a clinically significant tumor, it varies from 68 to 100%. So In some cases, it's very good, in other cases not. How is this big difference possible? It is because there are still some things that need to be clarified. It may be because there is a different study design. There are different MRI protocols. For example, in the past, sometimes spectroscopy was used. This was a technique with also one of the functional imaging techniques that had a very high negative predictive value. If the metabolites in the prostate were normal, the risk of a high-grade tumor was very low. There is also some doubt about the definition of a negative MRI. What do we have to do with the PIRATES 2, or what do we have to do with the PIRATES 3? Is the PIRATES 3 also a negative prostate? Yes, prostate MR, yes or no? There is some discussion about it. Also, the definition of a clinically significant prostate cancer is not clear. For example, a small Gleason 3+4 tumor, some clinicians will call this a significant tumor, others will call this not a significant tumor. But of course, this then changes the reports about the negative predictive value of the MRI. Also, patient selection is important if they are a family history, for example, and reader experience is also an important factor. We are working on the problems. There is a further improvement in the scan sequences. There is a further improvement in nomograms, in patient selection, clinical risk calculators. And also the reader experience has to increase. In expert centers, the quality of the MRI is very good. In centers with less experience, there's still some teaching needed. And also the PIRATES system may be optimized to improve the reader performance. So clinicians say, so okay, the negative predictive value of MRI is not always good. So they recommend to add the systematic truss biopsy. But as I showed before, the systematic truss biopsy also misses 30 to 40%. So it's also not the optimal solution. And we are more in favor for a clinical follow-up. If the MRI is negative, clinical suspicion is low, then no biopsy is needed in the prostate, or in case of a suspicious lesion on the right side, for example, no biopsy is needed of a lesion of the contralateral side, but use the PSA and clinical follow-up as a safety net when the MRI is negative. So to conclude, most important message is that a prostate MRI has an excellent sensitivity for detecting large aggressive cancers, but small low-grade cancers are frequently missed, but they are mostly insignificant tumors, so that's not too bad. The recent updates of the EAU and the AOA guidelines support the role of MRI before the biopsy in patients with elevated PSA. Biopsy may be omitted if the MRI is negative and the clinical suspicion is low. In biopsy-naive men with a positive MRI, perform a targeted and a systematic biopsy. In men with a previous negative biopsy but a positive MRI, perform targeted biopsy alone. MR targeted biopsy may be performed cognitive by truss MRI fusion or IMBOR MR guided. Thank you for your attention.
Okay, Peter, thank you very much for your interesting presentation about MRI and the different biopsy methods. I think it's really good to understand indeed the limitations of different MR methods and reading of the MRI. First of all, I want to mention it to everyone as well. Please put in your questions through the Q&A button on the bottom of your screen. If you go with the mouse to the bottom of your screen, you can send in the Q&A. Most of the questions we will answer after the other talks as well. So I think for now I want to thank Peter, and we do the most of the other questions after the talks. I think for now that's the easiest way. Our next speaker is Dr. Rogier van Stiphout of the Laurentius Hospital in the Netherlands. We're really pleased that he is here today to present his work and his experience. They used our system now for over 3 years in their center, and they recently published a nice article in the Dutch Journal of Medicine about their experience with their first 200 patients they performed. And I think it can give you a really nice overview of how they implement MR-guided biopsies and how they performing the MR-guided biopsies with their Soteria remote controlled manipulator. Rogier, I think if you are there, you can.
I'm here.
Okay.
Let's see if I can share the screen. Here it is, I hope.
Yeah.
Okay.
Yeah.
Thank
that
you,
looks good.
Martijn, for your kind introduction. Thank you, Professor Peter de Visser, I have to say now. Congratulations with that. And for your nice overview, thanks. I don't want any video. Okay, here we go. I have no disclosures. Content, I want to tell you, talk you through a little bit about our institution, patient selection or indications for MR guided biopsy, preparation, procedure, some cases, and I want to present our results. I'm a doctor in the Laurentius Ziekenhuis, and that's in the south of Holland. I'm an interventional radiologist, and we're a prostate center of excellence. Since 2016, we have a cooperation with the Radboud University in Nijmegen and Professor Jelle Barons, a pioneer in the PIRATES classification, as mentioned by Professor de Visser, educated our colleagues, Dr. Raad, Dr. Mok, and Dr. van Gorp, and myself to be prostate radiologists of excellence. We started MR-guided prostate biopsies when we saw the remote control manipulator in Nijmegen, and we were overwhelmed with its capacity. And we wrote a business case for our direction of the hospital, and it was granted. And we could start using the RCM in November 2017. We performed over 300 procedures, 329 as of this week, performed by 2 radiologists. We presented the first 200 cases, as Martijn mentioned, in the Dutch Journal of Medicine last month. And as Peter de Visser already mentioned, MRI targeted biopsy has proven to be feasible and accurate biopsy technique for prostate cancer. Patient selection and indication. You need to have good cooperation with your urologists and pathologists to set up a nice clinic. Patients with elevated PSA level, blood levels and suspicious lesions in the ideal world, PIRATES 4 and 5 are selected by multiparametric MRI, as was mentioned before. In our hospital, we do the biparametric MRI since this year. There's a new Dutch urology guideline, and that's also the European guideline, which states that positive MRI needs to be target biopsied. So the ideal technique for that will be the MRI. This is not yet implemented due to lack of capacity in the Netherlands and also by the corona pandemic this year. Then there's also other indications like a large prostate and a small PIRATES 4 lesion, a very basal anterior or laterally located lesion, patients who refuse truss, which is imaginable, patients with contradiction in proven Gleason 3+3, but suspicion of more aggressive component compared to the MRI characteristics. As mentioned, restriction of diffusion is very sensitive. Repetitive negative truss biopsies in highly suspicious patients, and second opinion for surrounding hospitals like truss, MRI fusion truss, who came out negative moreover. Then preparation on patient level. We gave the patients antibiotics, ciprofloxacin 400 milligrams 1 day prior, the day of biopsy and the day after. There's no rectal preparation but defecation prior to the procedure. Patient goes in head first prone position, of course. There's no need for anesthesia because we were only taking 2 samples. If the patient has 2 lesions, we tend to only attack the lesion that's most suspicious, has the most restrictive diffusion. Placement of the needle guide with a lubricant, And after the procedure, as of a precaution, we give the patients a sanitary napkin to put in their underwear. And of course, they can return at home immediately. This is a schematic overview. On the left side, we have the Armara room, and the right side, the control room. The robot is placed between the legs of the patient, and we can do all the directing from the control room. So we can manipulate the robot as well as scan control sequences to see how that's going and how the needle is moving towards the lesion. Of course, positioning of the patient is key. Here you see some cushions and pillows we use to position the patient, because I'll show you in the next slide, the orientation of the tip or the nozzle of the robot is downwards. The needle guide, as shown here, that's a little bit more broad than a ballpoint, is placed into that downwards pointing nozzle, and then the needle guide is even more pointing downwards when it's in here. So you have to adjust the position of the patient, and that's because you can imagine that if you have to biopsy very laterally located tumor, you want to point that needle guide at the start of your procedure towards that lesion. At least that will be very convenient if you are manipulating the needle guide in a later stadium. So because it's pointing downwards in left lateral lesion, you want to tilt the patient left side down or right side up if you want. And also you can position the robot more oblique on the plate where it's fixated on by vacuum. And so you have a convenient starting position for your procedure. Then patient goes in bore and sequences are scanned. We not always use the T2 image, but because we have that in our mind when we saw the detection MRI prior to the procedure, but you can, and sometimes it's helpful. We use the TrueFisp sequences, transfers, and sagittal to see how the needle guide is moving during the procedure, and if it's attacking the lesion as we want. Of course, I always use the diffusion weighted images because I always want to biopsy the most restrictive area, most restriction of diffusion. I think that would be also the most aggressive component of the tumor. And the software always shows the virtual needle biopsy trajectory. So that's very convenient. So you know how deep you want to insert your needle. Even that's said by told by the software, but I'll come to that later. Calibration. Well, the needle guide has a parallel orientated gadolinium inside. So if you double click on the tip of the needle guide, the software recognizes that structure, which is not elsewhere to be seen in the body. So the software is smart enough to pick up the needle guide itself. Then how do we determine the rotation point? You can imagine that if you have your rotation point outside the patient, you have to perform a lot of resistance to the muscle, and especially the anal sphincter or the buttocks. So I tend to place it on the level of the anal sphincter where you have less resistance and you can turn the needle guide any position you want. Well, how to determine the location? I just told we have the T2 weighted images, the TrueFisp, and the diffusion weighted images. And on the basis of that, we can determine our target lesion and perform the procedure. Now, how to determine the insert depth? Well, that's dependent of the anatomy, the anal rectal angle, and the position of the lesion, more apical or basal. So you know how to insert your needle guide up front based on your detection MRI. And you have to use more cushions underneath the patient if you want to go more apical, more basal, excuse me, because that will flatten the anal rectal angle. Then the procedure itself. We have a procedure time under 30 minutes in very simple apical lesions, because they're most simple for us. It can be performed in 15 minutes. It's much faster than manually, because when you do it manually, you have to scan, you have to take out the patient of the bore, go into the MR room, adjust the needle guide, and so forth and so forth. There's no talking to the patient in our hospital because we don't want him to move. And it's well tolerated. There's little to no pain, and therefore we don't need any anesthesia. Like I said, we performed more than 300 cases, and up to now we had 2 bleedings, that's rectal bleedings, and we had no cases of sepsis or ICU administration. There's a very steep learning curve. We performed the first 10, I guess, in when Martijn was with us. And as of that moment, we felt comfortable enough to do it ourselves. And so I think 10 to 20 cases must be enough for a radiologist to feel comfortable with the procedure. Then prostate cancer management. We have our several level agreement with our pathologist that we need the Gleason score within 24 hours, and the patient and urologist are very happy with that. So they can tell the patient who is very worrisome of his situation very fast which path is to be walked in the future. Starting up a one-stop shop model is our next goal. We are already starting with that. The urologist will see the patients early in the morning, and much later, a little more later in the morning, they will get their MRI scan at our department, and then we decide in a multidisciplinary team whether he gets a biopsy or not, and that will be performed in the afternoon after administration of amoxicillin. Next day, the results will be discussed with this urology, and patients will be happy, I guess. Then I have some cases for you to go through. First case is a 56-year-old man, PSA is 22, and he had a negative thrust twice. It's a very large lesion. If you listened well to Professor de Visser, you will pick this up as a P5 lesion in the transition zone, growing into the peripheral zone. This might be to be picked up with thrust biopsy, taking the 2 centimeter needle in regard, but it didn't twice. And when we performed the biopsy, it turned out to be a Gleason 4+4. Case 2, a 63-year-old man, PSA was 2.8, slowly progressive, but he had a family history, 2 brothers with prostate cancer, and he had an elevated PSA that was progressive, but 2 negative thrusts also, and was very worried. MRI was performed, and it showed a very anteriorly located P4 lesion or P5 lesion, maybe, on the right apex. And that location, anteriorly and very apical, is very difficult for thrust biopsy to reach. And you see with the RCM, you can upfront know that the needle will go through the most restrictive area very anteriorly. This was diagnosed as a Gleason 3+3. Then case number 3, a 73-year-old man, slightly elevated PSA, but on MRI, a very small lesion, 3 millimeters in a zone of P2-like changes in the peripheral zone. I'll show you later. And a very lateral location as seen here. You see the zone of maybe a low grade, then well, prostatitis. And here on the ADC, you see a very focal restriction, area of restriction of diffusion. We performed the biopsy right through that little lesion on the right side, subcapsular orientation and very lateral, and it turned out to be a Gleason 3+3. Then case number 4, the last one, is 67-year-old man, sorry, with a very large prostate. And these are very challenging cases. The PSA was 9. And you see there's a 200 milliliters of prostate, very large. The anal rectal angle is very, how do you call that? It's like 90 degrees. So you have to pass that angle and go up very deep into the rectum. Although there was a very small area of restriction, we managed to reach it. You see, the needle guide is almost vertically orientated, and we performed a biopsy, and it turned out to be a Gleason 3+4. So even these cases are suitable for the RCM. Then in short, I want to present our results. That's the results of the first 201 patients of the 329 we performed as of this week. Cancer detection rate of all prostate cancers, so that's the clinical significant and insignificant cancers, was in totally 58%. Cancer detections by Pirate score, well, Pirates 2 to 3, yes, we tend to biopsy those sometimes because patients are worrisome, and some urologists want to know, yeah, you have seen something, but the patient doesn't trust it, and we want to have a biopsy when we want to know. But you see, there's no detection of a clinical significant cancer in those cases. In Pirates 4 category, we have an overall cancer detection rate of 51%, Gleason 7, 23% or higher. Pirates 5, that's the best category, of course. Those are the largest tumors. They have the most restrictive diffusion. They are very suspicious. And we see that we have a clinical significant cancer rate detection of 44%. From our data, we saw that 51 patients had one or more prior negative TRUS biopsies, and in 52% of those patients we detected prostate cancer. So that's it's a huge number. Complications, I told you we have none, because we had 2 rectal bleedings, but they needed no intervention, and there were no cases of sepsis. I want to conclude with some take-home messages. After I drank some water. With the remote control manipulator, in-bore MRI guided biopsy is feasible and accurate. Positioning of the patient is prior, and it's key to success in the procedure. The procedure is less painful than TRUS and lower complication rates, and it's faster. Our data showed that 85% of the cancer detection rate, and that's equal to literature, and 52% of the negative TRUS patients were eventually diagnosed with a adenocarcinoma with the RCM. Thank you for your attention.
Thank you very much, Rogier. Thank you for the nice overview and explanation how you are performing the MRI guided biopsies and implemented that in your hospital. Just one quick question, because we see now some questions coming in, so really good to hear that. So at your sites, you sometimes do only targeted biopsies. So how is that in relation with the urologist? And they don't need the additional systematic biopsies? Or?
Well, in a prostate center of excellence, that's not necessary per se, but I think some of the urologists still do systematic biopsies. We know that in the surrounding hospitals, they still perform systematic truss biopsies.
Okay. So you're thinking, because if you have enough experience with the MRI, it should be sufficient to just do targeted biopsies.
Correct.
Okay. I think we can have a little more talk about this after our next talk as well. So our next speaker will be Dr. Maarten de Rooij. I'm really happy that he is coming, is able to give us a nice presentation. We hear quite a lot of questions like MR guided biopsies or MR targeted biopsies. It's really expensive, and I'm really happy that we have Maarten de Rooij to explain to you a little bit more about the cost effectiveness of MR targeted biopsies. He received his, obtained his PhD in Nijmegen in the group of Professor Jelle Barends in his thesis of multiparametric MRI in prostate cancer, diagnostic accuracy and the economic value. He is also the youngest recipient of the Louter Burr Award during the Society Conference of the Computed Body Tomography and Magnetic Resonance. So we're really happy that he is able today to give you a talk about the cost effectiveness of the prostate MR diagnostic pathway. So Maarten, you can start sharing your presentation. And the floor is yours. Thank you very much.
Yes, thank you, Martijn, for this introduction. Professor de Visser already told you a lot about the prostate cancer diagnosis and the problems with it. We know that with the truss-guided biopsy pathway, you have an overtreatment and overdiagnosis of insignificant prostate cancer. You will find tumors you don't want to find because they don't need treatment. And on the other hand, you have an undertreatment of clinically significant prostate cancer because the truss-guided biopsy is less able to find tumors in difficult to reach areas of the prostate, for instance, the anterior part of the prostate. And we know that an MRI can be helpful to improve the diagnostic pathway. That's why it's now included as upfront test in the guidelines of the EAU 20. But besides the direct clinical benefits, it's also interesting when you have a new technology to look at whether or not this new technology is affordable. So is this new technique affordable, and how does it improve the quality of life of the patients? And that's something you can assess by using cost effectiveness analysis. And with these kind of analysis, you try to optimize the allocation of limited healthcare resources. We know there is a limited healthcare budget, and you have to spend the money you have as good as possible. So by using cost effectiveness studies, you weigh the costs and effects of new healthcare interventions and compare these with the standard of care. We know that cost effectiveness studies are also important in clinical guidelines. In the new EAU guideline on prostate cancer, we see that the cost and cost effectiveness are mentioned quite some time, and it's very important also for reimbursement decisions. So cost effectiveness studies are used by national health systems, by health insurance companies, and by policymakers in hospital to decide whether or not to include a new technique in a diagnostic pathway, for instance. In this talk, I will focus especially on of course, on the prostate MR pathway. In a typical cost-effectiveness analysis, you have a certain population and you compare the standard of care with a new intervention, and you assess the costs and effect of both strategies and compare these and see what the incremental costs and effects are. Of course, for prostate cancer, we want all men to grow old very happy. And therefore, we look, of course, at the direct effects of an MR pathway on the number of clinically significant prostate cancer that are found, or the number of indolent prostate cancer that are found. But you also want to look at what the effect is of such a new strategy on the quality of life. And when doing a cost effectiveness analysis, you look at the QALYs, the so-called quality adjusted life years. And these are measured by the survival and the utilities of a certain health state. These utilities are actually a number from 0 to 1 on a continuous scale, where 0 represents the worst possible health state, the death, and 1 is a perfect health condition. And these utilities are given between 0 and 1. For instance, when you have an above the knee amputation, your utility will be around 0.2. When you have a heart failure, your utility will be around 0.6. And also for quality, for different therapies of prostate cancer, we have these utility values. And by combining these utility values with the survival in a different health state, you can calculate the QALY. It's important to remember that, for instance, 50 QALYs can be reached by a relatively short lifetime in full health, but also in a longer lifetime, for instance, 80 years, in a reduced health state. So going back to the simplified cost-effectiveness model, you start with men with a suspicion of prostate cancer, and you compare the old strategy, this trust-guided biopsy pathway, with an MR pathway. You assess the costs and the quality of both pathways, and you compare these. Then you can calculate the cost effectiveness. Typically, you assess the cost effectiveness in a cost effectiveness plane, with on the x-axis the QALYs of the incremental QALYs, or the difference between the old and the new strategy, and on the y-axis the costs, incremental costs, the difference between the old and the new strategy. Of course, when you have a new strategy that is way cheaper and much better in terms of quality of life compared to the old one, it's easy. A new technique will be cost effective because it's cheaper and better. It's also easy when a new technique is worse in terms of QALYs and is more expensive. You end up in the upper left corner. But when you end up in the upper right or the lower left corner, it becomes more difficult and you need to make some calculations. Typically, we use the incremental cost effectiveness ratio, the ICER, and that actually represents the costs per QALY gained. So how much does it cost to gain one QALY with a new technique? And you can calculate this by dividing the difference in cost by the difference in QALYs of the old and the new standard of care. And then when you have this ICER, you see whether it's below the willingness to pay. That means when the ICER is below the willingness to pay, the new technique is deemed cost effective. And this willingness to pay is actually a value that is stated by the society. And it's the willingness to pay to gain one extra QALY. In the UK, the NICE guidelines state this amount of money at around 20 to 30,000 per QALY gained. So when we go back to the cost effectiveness plane, the willingness to pay line represents the diagonal line in the graph. When your ICER is below the willingness to pay, you will end up in this part. Your new strategy will dominate the old one. When the ICER is above the willingness to pay, your old strategy will dominate. When you are able to spend more for one extra QALY, your new strategy is cost effectiveness in more cases. So you assess this cost effectiveness by building a decision analytical model. And that's actually a representation of the clinical pathway that needs to be as simple as possible, but not too simple and also not too detailed. What you do actually is building this clinical pathway and use input for your model from all available evidence. So you use evidence from diagnostic accuracy studies about the accuracy of the MRI, accuracy of the trust-guided biopsy, but you also use survival data about the survival, for instance, of men with a diagnosed clinically significant prostate cancer. You use quality of life data, the utility values of different therapies. And of course, you use the costs that are associated with the diagnostic tests and the therapies. You can also use the output of a trial as direct input for a model. And with this model, you can make careful considerations of the risk, the benefits, and the costs of different strategies, and which provides, of course, the insight into the added value of new diagnostic interventions. Also, it can identify gaps of knowledge. So when you are building your model, you see at what points evidence is missing. So you can see where new research needs to be focused on. For prostate cancer, this is a simplified version of one of the models we used. You start with a man with a suspicion of prostate cancer, and you compare different strategies with each other. In this case, the trust-guided biopsy strategy at the top and the MRI-guided biopsy strategy at the bottom. You use all the input data you get from the literature or expert opinion at the certain transition nodes. And at the end, you calculate all the different costs which are associated with such a strategy and the quality of life data, which is associated with different treatments and the survival data. Then at the end, you compare the strategies with each other and calculate the cost effectiveness. There are several studies that assess the cost effectiveness in the current literature. Studies from 2014 to 2018 from different countries that all assess the cost effectiveness of a trust-guided biopsy pathway versus an MRI pathway in biopsy-naive men. And what you actually see when you look at an overview of these studies is that in all studies, the MRI pathway has better quality adjusted life years at the end than the trust-guided biopsy. What you also see that is in a majority of cases, the MRI pathway is associated with higher costs. But then if you calculate the cost effectiveness, you see that in most of the cases, the ICER is well below the willingness to pay threshold and the MRI pathway is deemed cost effective. However, you have to bear in mind that there are also differences in these cost effective studies. And these differences are actually in three main areas: in the model structure, the model input, and the outcomes you study. First, the model structure. It's of course very important the way you build your model. So the clinical diagnostic pathway you're studying. Of course, they all start with men with an elevated PSA. But what's very important is the order of the tests. So do you, for instance, use urine markers? What do you do after a positive MRI? For instance, what type of biopsy do you use? Do you use systematic fusion? Or do you use systematic combined with fusion? Or do you only do inbore biopsy? Do you do cognitive biopsy? What do you do after a negative MRI? For instance, do you also use systematic biopsy in these cases? How does your follow-up look like? Do you do a repeat biopsy? Do you do a repeat MRI? And the time frame you're looking at. So for instance, do you only look at the short-term effects, or do you also study long-term effects or lifelong effects that all influence the eventual outcomes of your model and your cost effectiveness analysis? So be aware of that when reading cost effectiveness papers and looking at studies. This is an example of a study in the US, where on the x-axis the QALYs, the y-axis the costs per 1,000 men. They compare, for instance, the base case, which is the standard biopsy. So after an elevated PSA, trust biopsies, which is the old standard of care, with strategies that use MRI as upfront test. So they don't compare it one-to-one, but they use the base case and compare it with different MRI strategies. And that's interesting to see what happens then with the ICER, with the QALYs, and with the cost of these strategies. The most cost effectiveness strategy in this case is strategy 5, which is an MRI followed by combined biopsy and no biopsy in case of negative MRI. This has the highest QALYs, so the highest quality of life, but is also associated with higher costs than the base case analysis, but not higher than the willingness to pay. So the willingness to pay is stated as $30,000 in this case. So the 23 is lower. So the strategy 5 is deemed cost effective compared to strategy 1. If you actually look to another strategy, strategy 4, for instance, in which you use a combined biopsy and then in case of a negative MRI standard biopsy, you see that the costs are higher because you do more biopsies, but also the QALYs are lower than the strategy 5 who don't use the standard biopsy. And that's because in this case, you will find more insignificant tumors which will eventually be unnecessarily treated, so overdiagnosed and overtreated, which leads to a lower quality of life compared to strategy 5. So that's how you look in an overview to certain studies. This is another example, also from the US, and in this study, they compared strategy 1, which is standard biopsy after an elevated PSA. So standard biopsy means just doing the systematic truss, with 6 different MR strategies. And what they did here was looking at different biopsy techniques. So cognitive biopsy, in-bore biopsy, and fusion biopsy. And what you actually see if you look at these top 3 strategies is that the QALYs is higher than the standard biopsy technique. So you have better quality of life when using an MR strategy, but also lower cost. So lower cost than the standard biopsy. And that is because the MR pathways where you do no biopsy when in case of a negative MRI, you save costs in these patients. Also, you have higher QALYs because you are more accurate. They state in their study that the in-bore biopsy is the most accurate method, so that leads eventually to the most accurate diagnosis and thus most accurate and highest QALYs. And that's why this strategy is cost effective compared to the standard biopsy, and also the first strategy is also cost effective compared to standard biopsy. What we do in our hospital is, in case of a clinical suspicion, we use MRI, of course, after the suspicion, and based on the pyretes, we do a follow-up or a targeted biopsy. In case of a pyretes 3, it's dependent on the clinical suspicion of these patients, whether or not to do a target biopsy. Based on these outcomes and based on the clinical parameters, we make a treatment plan. The targeted biopsy we do, we decide based on the lesion whether we do an in-bore biopsy or a fusion biopsy. In case of a smaller, more difficult to reach area, we use in-bore biopsies, and we use fusion biopsies for the other targets. Also important when you look at cost effectiveness studies is to have an idea of what input is used in the model. You can use input from systematic reviews when available, but in some cases, especially for new techniques, you have to have expert opinion or assumptions in your model, because you simply don't have studies yet that provide input on these points. Also, what I just told in the previous slides is that you can use outcomes for the trial as input for your model, as what the people from the PROMISE trial did. Also, it's important to see what definitions are used for instance, clinically significant prostate cancer. How many men have prostate cancer in the population that they model, and the proportion of these patients with clinically significant prostate cancer, because this all leads to the amount of treatment options you have. This is interesting to see what they use as input from cost perspective. So for instance, the upper table is a table from a US-based study. The middle one is from a Canadian healthcare situation, and the bottom part is from our situation in the Radboud. And when you compare the MRI costs, for instance, you see in Canada and the US, you have costs of around $900, while in the Netherlands, MRI tends to be cheaper. And for biopsy, there are also large differences. We know in the US, biopsy is can be very expensive, while in Canada and in the Netherlands, the costs are much lower. So this also influences, of course, the eventual outcomes of your model. It's also important to know what kind of healthcare setting is used. Is it only the costs in the healthcare, or is it also the costs that are in the whole lifetime for society? What's important to do, especially when you have uncertain input parameters, where you have to make the assumption, is that you use sensitivity analyses. And that is actually that you vary the input data on this parameter to see what it does with the outcome of your cost effectiveness. In the future, I think it would be very nice to have more transparent model. For instance, that is made by cost effectiveness researchers around Europe with clinical scenarios that represent the current clinical pathway, and that you use the most reliable source as input, and that you can update this when new evidence becomes available, that you're able to identify the gaps of knowledge, and that you can easily adapt the costs for your own country and your own healthcare situation of the model to your specific situation. So to conclude, decision analytic models can be used to identify the risk, the cost, and potential benefits of new diagnostic interventions. They're used to optimize the allocation of limited healthcare resources. It gives you knowledge about the important factors that contribute to the outcomes. And what we see in the current literature is that the MRI strategy is cost effective compared to trust-guided biopsy. But you have to bear in mind that the variability in the results between these studies is quite large because of the heterogeneity in the model structure and the input of the data. That's it.
Thank you very much. I see that we are it's already 5:30 and some attendees are leaving. So I think I want to thank you all very much for all the information and the presentations. The questions we haven't answered, we will try to answer by email later on. Just to let you know, if you are interested more to learn really about the details about our system, next Thursday we will give another demonstration just by Soteria. We will go more into the detail of the system, which I have over here as well. I also want to announce that there's with the Radboud University Medical Center, they have really nice courses coming up where you can register on-site courses to learn more about prostate MRI. It's both for radiologists as well as for urologists. And it's really useful to learn CME accredited as well to learn more about prostate MRI. And by that, I want to thank you all. If you want to have any information, please contact us. We're happy to answer the questions you might still have.